Hey, welcome back. If you're new here, hi, I'm so glad you found this channel. We talk about all things pregnancy, birth, and postpartum. The real stuff, not the sugar-coated version. And today, we're talking about one of the most Googled topics in all of pregnancy, the epidural. Should you get one? What does it actually feel like? What are the risks for you and for your baby? Does it slow down labor? Does it affect breastfeeding? Will you regret it if you get one, or if you don't? I get asked these questions literally every single week. So today, I'm going to give you the most thorough, most honest, most complete breakdown I possibly can. We're going to go through what an epidural actually is, how it's placed, the different types available, every single pro and every single con, including some that don't get talked about enough, what happens to your baby who can't get one, questions to ask your care team, and natural alternatives if you're considering going without. This is a long one, so grab a snack, get comfortable, and let's get into it. Section 1. What is an epidural? Let's start from the very beginning. An epidural is a form of regional anesthesia, meaning it numbs a specific region of your body rather than putting you fully to sleep. It's the most widely used method of pain relief during labor and delivery. The medication is delivered into what's called the epidural space, a narrow area in your lower back that sits just outside the membrane surrounding your spinal cord. Anesthetic and sometimes opioid medications are injected into this space, where they bathe the nerve roots that carry pain signals from your uterus, cervix, and vaginal canal. The result? The pain of contractions, that intense, cramping, pressure wave sensation, is dramatically reduced, or for many women, completely eliminated. Here's the important distinction. An epidural is not a spinal block, though the two are sometimes confused. A spinal block is a one-time injection directly into the spinal fluid, often used for C-sections. An epidural uses a catheter, a tiny flexible tube, left in place so medication can be delivered continuously throughout your labor. Section 2. How is an epidural placed? A lot of women are nervous about the placement itself, so let's walk through exactly what happens, step by step. Step 1. Positioning. You'll either sit on the edge of the bed and curl forward, like you're trying to make your spine into a C shape, or you'll lie on your side in a fetal position. The goal is to open up the spaces between your vertebrae as much as possible. Your nurse or midwife will often hold your hands or support you during this. Step 2. Numbing the skin. The anesthesiologist will clean the area on your lower back with an antiseptic solution. Then they'll inject a small amount of local anesthetic into the skin and tissue to numb the area. This is the pinching sting most people feel. It's similar to getting a dental injection. Brief and sharp. Step 3. Placing the needle. Once the area is numb, the larger epidural needle is inserted. But because your skin is already numbed, most women describe this as pressure rather than pain. The needle is guided into the epidural space. You may be asked to stay very still. Particularly important is not moving during a contraction, which can be genuinely hard. Tell your care team if one is coming. Step 4. Threading the catheter. Once the needle is correctly positioned, a thin, flexible plastic catheter is threaded through it into the epidural space. The needle is then removed. The catheter stays. This catheter is taped to your back and shoulder to keep it secure. Step 5. Test dose and loading dose. A small test dose is given first to confirm the catheter is correctly placed and not accidentally in a blood vessel or the spinal space. Then the full loading dose is administered. Most women begin to feel relief within 10-20 minutes. Step 6. Ongoing delivery. From there, medication is delivered either continuously via a pump through patient-controlled top-ups, where you press a button when you need more, or a combination of both. The whole process typically takes 10-20 minutes from start to finish. Most women say it was far less painful than they expected. Section 3. Types of epidurals. Not all epidurals are the same. Let's break down the main types. Standard epidural. This is the traditional form. It numbs the lower half of your body quite significantly. You'll feel pressure, but not pain. You'll have limited ability to move your legs. You'll need a urinary catheter because you won't be able to feel the urge to urinate. This is still the most common type in many hospitals. Low-dose or walking epidural. combined spinal epidural or CSE. This combines a small spinal injection for fast-acting relief with an epidural catheter for ongoing medication. The doses are lower, which means you retain more sensation and motor function. Some women can actually walk, though many hospitals still require continuous fetal monitoring, which keeps you fairly close to the bed. Pain relief may be slightly less complete than a full epidural. Patient-controlled epidural analgesia, PCEA. This allows you to press a button to self-administer additional boluses of medication within preset safety limits. Research shows women who have control over their own dosing tend to use less medication overall and report higher satisfaction. It's increasingly common and worth asking your hospital about. Programmed intermittent epidural, bolus, PIB. Instead of a continuous drip, medication is delivered in automatic scheduled boluses, pulses of medication at regular intervals. Research suggests this may provide better pain coverage with less total drug and potentially fewer side effects than a continuous infusion. Ask your anesthesiologist if this is available. The type of epidural available to you will depend on your hospital, the anesthesiologist on call, and your specific medical situation. Section 4. The pros in detail. Okay, now let's get into the benefits. And I want to be thorough here because there are real, meaningful reasons so many women choose this. Pro number 1, highly effective pain relief. This is the most obvious one, but it's worth saying clearly. Epidurals work. They are consistently rated by women as the most effective form of pain relief available during labor. Not takes the edge off. For most women, they eliminate the pain of contractions almost entirely. Pain in labor is not trivial. Surveys consistently rate it as one of the most intense pains experiences a human can have. For many women, the ability to have that pain completely controlled is transformative. It changes the entire experience of birth. Pro number 2, you remain fully conscious and present. Unlike general anesthesia, an epidural leaves you fully awake, alert, and able to communicate. You can talk to your partner. You can ask your midwife questions. You can hear and respond to your baby's heartbeat on the monitor. You can make decisions in real time. And when your baby is born, you are there, fully present for that first moment. This is a genuinely significant benefit. Many women say it allowed them to feel like active participants in their birth, not just patients enduring it. Pro number 3, rest and recovery during long labors. Labor is a marathon. For first-time mothers, it's not uncommon for active labor to last 12, 16, even 24-plus hours. If you've been contracting every 2 to 3 minutes for 10 hours straight, the fatigue is staggering, both physically and mentally. An epidural allows you to rest. Some women sleep for several hours in labor. When it's time to push, they have energy reserves that women without pain relief sometimes don't. For long labors especially, this rest can be genuinely medically beneficial. Pro for 4, reduces psychological distress and anxiety. Pain activates your body's stress response. Cortisol and adrenaline spike. Your heart rate increases, you may panic or feel out of control. For some women, this stress response can actually slow labor by counteracting oxytocin. When the pain is controlled, many women describe feeling a profound shift, from terror to calm, from helplessness to agency. The psychological relief is not separate from the physical experience. It's deeply intertwined with it. A calmer mother is often a labor that progresses better. This is particularly important for women who have experienced previous trauma, including sexual trauma or previous traumatic births. Pro number 5, facilitates medical interventions if needed. Labor doesn't always go as planned. If your baby needs to be assisted with forceps or vacuum extraction, having an epidural in place means those procedures can be performed without additional emergency anesthesia. If an emergency C-section becomes necessary, your epidural catheter can often be topped up with stronger medication very quickly, far faster and safer than inducing general anesthesia. This is not a small thing. When emergencies happen in labor, having anesthesia already in place can be genuinely life-saving for mother or baby, or both. Pro number 6 allows focus on the emotional experience of birth. When pain is no longer consuming your entire focus, you can be emotionally present. You can hold your partner's hand, have a conversation, cry, laugh, breathe through the experience with intention rather than survival mode. Many women who've had both medicated and unmedicated births say the epidural births felt more emotionally meaningful because they were able to actually be there rather than just endure. Pro number 7 can be beneficial in specific medical situations. For women with certain heart conditions, severe preeclampsia, or other high-risk conditions, epidurals can be medically recommended because they reduce the cardiovascular stress of labor. Your care team may actively encourage one in some cases. Section 5. The cons, in detail. Now the other side. And I want to be just as thorough here because you deserve the full picture. Con for 1. Hypotension, drop in blood pressure. This is one of the most common side effects, occurring in roughly 10 to 30% of cases. The medication causes the blood vessels to dilate, which can cause blood pressure to drop suddenly. Symptoms include dizziness, nausea, and lightheadedness. In significant cases, it can temporarily reduce blood flow to the placenta, which affects the baby's heart rate. To prevent this, you'll be given IV fluids before the epidural is placed, and your blood pressure will be monitored very closely, typically every 5 minutes for the first 20 minutes after placement. Medications are on hand to treat it quickly if it does occur. For most women, any drop is brief and well managed. However, it's a real risk and worth knowing about. Con number 2, potential to slow labor. This is one of the most debated topics in obstetrics, and the research is genuinely mixed. Some studies suggest epidurals, particularly those placed early in labor, are associated with longer first and second stages of labor. Other large, well-designed studies find no significant effect on labor duration. What does seem to be fairly consistent is that the second stage of labor, the pushing phase, may be slightly longer with an epidural because you have reduced sensation and may push less effectively. Many hospitals respond to a prolonged labor by using pitocin, synthetic oxytocin, to strengthen contractions. This is a real cascade to be aware of. Epidural, slower labor. Pitocin, stronger contractions. Potential need for more pain relief. Being aware of this doesn't mean avoiding the epidural, but it's worth discussing with your provider. Con number 3, reduced ability to push effectively. Because the epidural reduces sensation in your lower body, you may not be able to feel your contractions well enough to push with them effectively. Pushing is an active, muscular process, and it's harder when you can't fully sense what's happening. Some providers allow the epidural to wear off somewhat during the pushing phase, called laboring down, to improve sensation before actively pushing. Low-dose epidurals help with this as well. Ask about your hospital's approach. Con number 4, limited mobility. Once you have an epidural, particularly a full-dose one, you'll be confined to the bed. You won't be able to walk, use a birth ball freely, labor on your hands and knees, get into the shower, or use other position changes that many women find helpful for managing pain and facilitating baby's descent. If freedom of movement matters to your birth vision, this is a significant trade-off. A low-dose or walking epidural partially addresses this, but monitoring equipment still limits how far you can go. Con number 5, dural puncture headache. In approximately 1 to 2% of cases, the epidural needle accidentally punctures the dura, the membrane surrounding the spinal cord, causing cerebrospinal fluid to leak. This results in a severe postural headache that is often debilitating. It typically comes on 24-48 hours after delivery and gets much worse when upright. Treatment involves hydration, caffeine, and if necessary, a procedure called a blood patch, where a small amount of your own blood is injected into the epidural space to seal the leak. This is highly effective, but does require an additional procedure postpartum, which can be stressful with a newborn. Con number 6, fever, epidural-associated maternal fever. Multiple studies have consistently found that epidurals increase the risk of developing a fever over 30 degrees 100.4 degrees during labor. This occurs in somewhere between 15 to 30% orange shards of women with epidurals versus 1 to 5% without. The mechanism is still not fully understood. It may be related to inflammation rather than infection. The problem is that a maternal fever during labor can be mistaken for infection, chorioamnionitis, which triggers a cascade. The baby may be evaluated for infection, blood cultures may be drawn, antibiotics may be started, and the baby may be admitted to the NICU for observation. All for a fever that was caused by the epidural, not an actual infection. This is one of the more significant downstream risks of epidurals that isn't talked about enough. If you develop a fever after your epidural, advocate clearly for your care team to consider epidural-associated fever as a cause before assuming infection. Con number 7, itching, pruritus. A common side effect, particularly if opioids are included in the epidural medication, is itching, especially on the face, neck, and chest. For some women, this is mild. For others, it's intensely uncomfortable. It can be treated with medication, but it's worth knowing it can happen. Consider 8, shivering. Uncontrollable shivering or trembling is another relatively common side effect. It usually passes on its own and isn't dangerous, but it can be alarming and uncomfortable. Con number 9, urinary catheter required. Because the epidural numbs the nerves that signal bladder fullness, you'll need a urinary catheter inserted to drain your bladder. This is done after the epidural takes effect, so you won't feel it. The catheter stays in place during labor. Some women find this completely fine. Others find it uncomfortable or find it contributes to postpartum urinary issues. Con number 10, back soreness at injection site. Many women experience soreness at the site where the epidural was placed for days or even weeks after delivery. This is almost always minor and resolves on its own. There is a widespread belief that epidurals cause long-term back pain. The research does not support this. Studies comparing women who had epidurals to those who didn't show no significant difference in rates of chronic back pain. The back pain many women experience postpartum is real, but it's related to the physical demands of pregnancy and delivery, not the epidural itself. Con 11, emotional impact, the guilt factor. This one doesn't get talked about nearly enough. Many women who planned unmedicated births and ended up getting epidurals, whether by choice or necessity, experience significant feelings of guilt, failure, or disappointment afterward. These feelings are real, and they matter. Birth is a deeply personal experience, and it can be painful, emotionally, when it doesn't go the way you hoped. I want to say this clearly. Getting an epidural is not failure. It is not weakness. It is not taking the easy way out. It is using available medical support to manage one of the most intense physical experiences of your life. Full stop. If you're listening to this and you've felt that guilt, you are not alone and you didn't fail. Your baby arrived. That is what matters. Section 6. What about the baby? This is the question I get asked most often. Will the epidural hurt my baby? Here's what the research actually says. Medication transfer. Small amounts of epidural medication do cross the placenta. However, the doses used in modern epidurals are much lower than those used in earlier decades, and studies consistently show no significant adverse effects on newborn outcomes. At standard doses. APGAR scores. Multiple large studies have found no significant difference in APGAR scores, the assessment done at 1 and 5 minutes after birth, between babies born with or without epidurals. Fetal heart rate changes. Because epidurals can cause maternal hypotension, they can temporarily affect the baby's heart rate. This is why continuous fetal monitoring is required. The changes are usually brief and well managed, but in rare cases, they may require intervention. Breastfeeding. This is a topic of ongoing research. Some studies suggest that epidurals, particularly those containing fentanyl, may make newborns slightly more sleepy or less alert in the first hours after birth, potentially making the initial latch more difficult. However, the research is mixed, and many other factors, labor length, delivery method, skin-to-skin contact, and hospital support, also significantly affect breastfeeding initiation. The evidence does hard not suggest that epidurals make breastfeeding impossible or even significantly harder for most women. If breastfeeding is very important to you, discuss it with your care team, request skin-to-skin immediately after birth, and ask for lactation support. These factors matter far more than whether you had an epidural. Long-term effects on the child. Multiple large studies have looked at outcomes for children's years after birth and found no significant differences related to maternal epidural use. There is no credible evidence that epidurals cause long-term harm to children. Section 7. Who can't get an epidural? Epidurals are not an option for everyone. You may not be able to receive one if blood clotting disorders or anticoagulant medications. Placing an epidural needle carries a small risk of bleeding. If you have a clotting disorder, or if you're on blood thinners like heparin or low molecular weight heparin, the timing and safety of an epidural needs to be carefully evaluated by your anesthesiologist. Local infection at the injection site. An active skin infection, boil, or abscess at the injection site makes it unsafe to proceed. There's a risk of introducing bacteria into the epidural space, which could cause a serious infection of the spinal cord. Some spinal conditions or previous back surgeries. Certain spinal abnormalities, previous fusion surgery, or hardware in the spine may make placing an epidural technically difficult or impossible. This doesn't mean you automatically can't have one. It depends on the specifics. Discuss your history with an anesthesiologist, ideally before your due date. Very rapidly progressing labor. If you arrive at the hospital at 9 centimeters and your baby is coming in the next 20 minutes, there simply may not be time to safely place an epidural. This is why, if you know you want one, communicating that clearly and early when you arrive is important. Low platelet count. A platelet count below a certain threshold, often around 70,000 to 80,000 mmol, though this varies by provider, increases bleeding risk and may preclude an epidural. This is assessed by the anesthesiologist. If you have any of these situations, discuss it specifically with your care team well before your due date so you can plan accordingly. It's Section 8, Questions to Ask Your Care Team. Being informed before labor starts makes an enormous difference. Here are the questions worth asking at your prenatal appointments or hospital tour. 1. Is an anesthesiologist available 24 hours a day, 7 days a week at this facility? Not all hospitals have round-the-clock anesthesia coverage. In some smaller or rural facilities, you may have to wait. How do I request an epidural once I'm in labor? Is there a typical wait time? 3. Does your facility offer walking epidurals or PCEA options? 4. What is your hospital's approach to the pushing phase with an epidural? Do you allow the dose to reduce or practice laboring down? 5. If I have a medical condition, X, spinal hardware, blood thinners, low platelets, can you review my chart in advance with the anesthesiologist? 6. What is your hospital's epidural-related fever protocol, and how does that affect my baby? 7. What natural or alternative pain relief options are available here? Birthing pools, nitrous oxide, birth balls, mobile monitoring. Getting these answers ahead of time means you're not trying to research during active labor. Write them down. Put them in your birth plan. Section 9. Natural alternatives to an epidural. If you're considering going without an epidural, or want to delay it as long as possible, here are the evidence-based and commonly used alternatives. Hydrotherapy, water. Laboring in a warm bath or shower is one of the most effective natural pain relief methods available. Warm water relaxes muscles, reduces tension, provides sensory counter-stimulation, and many women report it dramatically reduces the perceived intensity of contractions. Many hospitals now have birthing pools. Ask if yours does. Movement and position changes. Walking, swaying, using a birth ball, laboring on hands and knees, lunging, rocking. Movement genuinely helps. It can encourage baby to descend into a better position, which can reduce the intensity and duration of labor. If movement is important to you, it's one of the reasons to weigh carefully before getting an epidural. Nitrous oxide, laughing gas. Available in many hospitals, though not all in the U.S., nitrous oxide is inhaled through a mask or mouthpiece during contractions. It doesn't eliminate pain, but blunts it and creates a sense of dissociation. It wears off within minutes, so you control when you use it. Many women find it takes the edge off enough to keep going without an epidural. It's safe for the baby and doesn't affect your mobility. TENS machine, transcutaneous electrical nerve stimulation. Small electrodes placed on the lower back deliver mild electrical pulses that interfere with pain signals. Evidence is mixed. It's most useful in early labor. Many women rent or buy one to use at home during early labor before going to the hospital. Massage and counter pressure. Having a partner or doula apply firm counter pressure to the lower back during contractions can provide genuine relief, particularly for back labor, where the baby's position causes intense pressure against the spine. Breathing techniques and mindfulness. Lamaze, hypnobirthing, and other breathing-focused techniques don't eliminate pain but can significantly change your relationship to it, reducing panic, lowering adrenaline, and helping you work with contractions rather than against them. These are most effective when practiced extensively before labor. A doula. Studies consistently show that continuous labor support from a trained doula reduces the need for pain medication, reduces the likelihood of C-section, and improves birth outcomes and satisfaction. If you want to attempt an unmedicated birth, a doula is one of the highest impact investments you can make. None of these alternatives are as powerful as an epidural for pain relief, but they can meaningfully reduce suffering, delay the need for an epidural, or help some women get through labor without one. Section 10. Making the decision. So how do you decide? There's no formula. There's no right answer. But here are some questions to sit with. What matters most to you about your birth experience? If feeling fully in control, mobile, and unmedicated is deeply important to you, that's valid and worth fighting for. Build your plan around that, including the support systems to help you achieve it. If getting through labor with the least possible suffering, being rested, and being present and calm is what matters most, an epidural might be exactly right for you. That's equally valid. What does your health picture look like? Some medical situations make an epidural strongly advisable. Others might complicate placement. Know your picture. What is your pain tolerance history? Be honest with yourself. This isn't about toughness, it's about self-knowledge. Some women sail through unmedicated labor, others describe it as unpredictable. Neither experience says anything about your character. Are you flexible? Make a birth preference, not a rigid birth plan. Know what you want, communicate it clearly, but hold it loosely. Labor is unpredictable. The woman who goes in dead set against an epidural and eventually asks for one, and then spirals into guilt, often suffers more than necessary. Give yourself permission to change your mind without judgment. One final note. Whether you get an epidural or not, your birth is valid. Your experience matters. Your choices are yours to make with good information and good support. That's what this channel is here for. Okay, that was a big one. If you made it to the end, genuinely thank you. I hope this gave you the information you were looking for, and I hope it leaves you feeling more prepared and less anxious. If this video helped you, please give it a thumbs up. It helps this channel reach more pregnant women and families who could really use this information. Drop your questions in the comments. Seriously, I read every single one. Tell me, are you planning to get an epidural? Going unmedicated? Still undecided? I'd love to know where you're at. Don't forget to subscribe and hit the bell so you don't miss our upcoming videos. We've got one coming up on natural pain relief techniques in detail, one on what nobody tells you about the pushing phase, and one on C-section recovery that so many of you have been asking for. Thank you so much for being here. Take care of yourself, trust your body, trust your instincts, and know that however your birth unfolds, you are doing something incredible. I'll see you in the next one.